So we have discussed the features of core pulmonale, classification of core pulmonale, then details of the different types of pulmonary embolism, the pathological features, then clinical features and signs. Then we can move on to the investigations in pulmonary embolism. First of all, chest radiograph. Chest radiograph is very useful in embolism, mainly in infarction. Opacity, you can see opacity in pulmonary infarction. We have discussed that. You can see a triangular shaped opacity with the base of the triangle directing towards the pleural surface and the apex of the triangle pointing towards the hilum. That's a particular type of opacity you get in pulmonary infarction. Then in chest X-ray you can see raised diaphragm, then linear opacities. If you are getting linear opacities, it is suggestive of atelectasis. Then there is a sign called Westmark sign. X-ray, there is a sign called West, W-E-S-T-M-A-R-K. Westmark sign. And it is the presence of diminution of vascular marking. This is the diminution of vascular marking in a localized area, which is seen in some cases of pulmonary infarction. So, this is due to the stoppage of blood supply. There is diminution of, normally you can see vascular markings in X-ray to a particular level. And when there is diminution of vascular marking in a particular area, then that sign is called Westmark sign. Then that's about the chest radiograph. Then along with the other infarction, there are other features, or there is pleural involvement leading to effusion or something like that. Then other features will be there in chest X-ray. Then features of atelectasis also will be there in chest X-ray. Then, so you can see changes accordingly, depending upon the status of the presentation. Then ECG is also an important investigation in case of pulmonary infarction. Then blood gas analysis reveals hypoxia, even at rest or during exercise. Then pulmonary angiography is another useful investigation. Here we can see intraluminal fill-in defects in several fillings, and there is a sharp cutoff in vessels greater than 2.5 mm in diameter. You can see a cutoff that is usually at the level of blockage. That I won't move beyond that blockage. So you can see a cutoff in pulmonary angiography. Then lung scans are there. There is perfusion lung scan, ventilation scans are there. All this can differentiate from pulmonary embolism from other conditions. And there will be ventilation perfusion mismatch. There is ventilation perfusion mismatch, it is definitely a pulmonary embolism. Then echocardiogram. Echocardiogram is also another useful investigation. It can detect large thrombus. And one useful feature is it can detect large embolism in the right atrium, or in the ventricular outflow tract, or even in the main pulmonary artery. And if there is, the ventricular size is increased or not, about the wall movements, etc., all this can be recorded in echocardiogram. So it's also a useful investigative procedure. Then lower limb venography or Doppler studies of leg veins are also used. Is also a useful investigation in case of pulmonary embolism. So these are the common investigations. Then we can move on to the management of pulmonary embolism. It's also very important. First of all, if the patient survives the initial phase, the patient should be moved to the hospital at the earliest. Patient is put to bed, then oxygen is administered, and closed chest cardiac massage is started. And if you are detecting or if you are smelling pulmonary embolism, so we have discussed about massive pulmonary embolism, the presentation, the patient will collapse within minutes. Then if you are getting a patient like that, you have to start closed chest cardiac massage immediately. It can increase cardiac output. And helps to fragment the thrombus and drive it to peripheral branches. So it can save the patient. So if you give closed chest cardiac massage or simple CPR, it can fragment the big thrombus and can drive the thrombus the fragments into peripheral branches. So there will be restoration of blood supply, even partial restoration of blood supply, which will be helpful for the patient. It can save the patient. And after hospitalization, they will give morphine or pethidine preparation for relief of pain and apprehension. Then transcatheter suction embolectomy can be done in case of embolism. Then another mode of management is administration of anticoagulants. So usually the main cause of pulmonary embolism is thromboembolism. So the use of anticoagulants might be helpful. So it is given to prevent thrombosis and to prevent the extension of float. And the most useful drug or the preparation given is heparin. Heparin is the most powerful anticoagulant and is given parenterally. It may be given intravenously or even deep intramuscularly. Is usually given parenterally. Then the activated plasma thromboplasmin time or APTT, activated plasma thromboplasmin time, is maintained at 1.5 to 2 times of the normal counted value. And another important advantage of heparin is that it does not cross the placenta and it does not appear in milk also. So it can be safely given during pregnancy or even during lactation. That's an advantage of heparin. But there are complications of after giving heparin also, like GIT bleeding, then bleeding into tissues, bleeding into retroperitoneal space, bleeding into adrenals, etc. And there are contraindications also for heparin, to administer heparin, that is traumatic conditions, if there is perforated ulcer, peptic ulcer, then bleeding disorders, then recent cerebral hemorrhage, hypertension, infective endocarditis. All these are contraindications for heparin. So heparin is a life-saving remedy. It's a powerful anticoagulant. It can be usually given parenterally and is given intravenously or deep intramuscularly also. Then the complications and contraindications also that should also be looked into. Then there are long-term, this is the emergency management, then there are long-term anticoagulation techniques also. It is done by giving oral anticoagulants. There are certain oral anticoagulants. For example, coumarin, COUMARIN, coumarin or phenydione. Then one of the most popular oral anticoagulant is warfarin sodium. All these are oral anticoagulants. Then there is thrombolytic therapy also. We have discussed anticoagulant therapy. Then there is thrombolytic therapy also. This is done or employed to dissolve the clot already formed. This is employed to dissolve the clot already formed and recanalize the occluded vessels. And certain enzymes are used for this purpose. For example, streptokinase. You might have heard of streptokinase. And the streptokinase is given intravenously. Then urokinase is there. Then another preparation called tissue plasminogen activator or TPA. Tissue plasminogen activator or TPA. All these are, this TPA is used locally at the site of emboli. So these are thrombolytic therapy. Then there are surgical measures also for pulmonary embolism. That is emergency removal of clot itself. The clot is formed, and even after administrating this doing thrombolytic therapy, the clot is not dissolving. We have to remove it by surgical measures. So emergency removal of clot from the pulmonary artery is essential. Then another procedure is inferior vena cava ligation, and it is done to prevent recurrent pulmonary thromboembolism. That is inferior vena cava ligation. Then is another technique called venous interruption. Venous interruption is there. Here there is implantation of an umbrella-like device in the inferior vena cava. There is implantation of an umbrella-like device in the inferior vena cava, which filters off emboli from traveling centripetally. So, prevents emboli from reaching the heart. Then it is usually indicated in recurrent pulmonary embolism, or is indicated in pulmonary hypertension. The thrombolytic therapy is contraindicated. It is indicated in conditions where thrombolytic therapy is contraindicated. That is venous interruption or implantation of umbrella-like device in inferior vena cava. Then other measures like administration of antibiotics. They will administer antibiotics to prevent infection. So after infection there can be infection also. So they will administer antibiotics. Then to control shock or prevent shock, vasopressor drugs are given. Then to relieve dyspnea, they will give aminophylline injections or intravenous aminophylline. Then digitalis, they will give digitalis for heart failure. Then correction of acidosis, that's very important. Correction of acidosis, that is by giving sodium bicarbonate IV. Then these are the measures in hospital or after hospitalization. Then there are certain preventive measures to prevent embolization. The general measures are there, and we have to advise the patient. And this include elevation of legs, at night. Elevation of legs to collapse the veins. Then use of elastic stockings. Certain stockings are there. Elastic stockings. Then leg exercises. You can advise leg exercises to favor muscle pump or increase the venous return. So these are the general measures we can advise. So that's about pulmonary embolism. Then we can move on to chronic pulmonary embolism.